third one is lateral mitral annular Doppler, and fourth one is four chamber window. Diastolic dysfunction, atrial volume, myocardial strain for LVEF calculation. Okay. Mitral inflow using pulse wave Doppler. This is hepatic wave Doppler, and this is a lateral mitral annular Doppler. E prime is about 4 cm. So usually is less than about 8 cm. No, see here 4 cm. This is apical 4 chamber window. And the fourth conditions are arrhythmogenic right ventricular cardiomyopathy, which means first is dilated cardiomyopathy, second is obstructive hypertrophic cardiomyopathy, which means asymmetrical septal hypertrophy also sometimes present. Third one is restrictive cardiomyopathy. Fourth one is arrhythmogenic right ventricular cardiomyopathy. Right ventricle get impaired, right ventricle get dilated, and arrhythmia is also present. So right ventricular function get impaired. It is a genetic disorder. So the right ventricle of myocardium leads to arrhythmias and RV dysfunction. Okay. Echo findings are RV dilatation and dysfunction. Regional wall motion abnormalities also present. What is regional wall motion abnormalities are? The systolic function get impaired. The segments, so there are 17 segments are there in ventricles. Once if it is get necrosed, cells are get death, which means MI. We say MI. Once in MI condition, the systolic function get impaired. That time we called as regional wall motion abnormalities. So RV get dilated and dysfunction, and regional wall motions of abnormalities of RV present, and RV outflow tract dilatations. RV outflow tract dilatation, which means outflow tract means what? Pulmonary arteries area. Correct? Infundibulum. A pulmonary artery. A blood from right ventricle is passed through what? Lung with via pulmonary. So RV outflow tract is about pulmonary artery. So pulmonary artery outflow tract get dilated, and normal or mildly impaired LV function. Why it is get mildly impaired means once an RV get dilated, right ventricle get dilated, the pressure in right ventricle get increased, volume also get increased. It start to push LV. Okay. Once it's try to pushing LV, the LV movement get called as jerky septum IVS. That is impaired in contraction, and also the septum get jerky. Normal contraction get absent. Jerky or bounce movement. Okay. Jerky septum IVS is present. According to the sign, the hyper-reflective moderator band also present with regional dyskinesia. Key measurements are RV dimensions need to be taken, RV fractional area, tricuspid annular plane, TAPSE, tricuspid annular plane in systolic excursion also have been followed. See the image, this is 4 chamber window, RV apex are akinetic. RV get dilated and trabeculae are more visible. RV moderator band also more visible. And last one is non-compaction of cardiomyopathy, which means excessive trabeculations and deep recess in LV myocardium. Excess in trabeculation. LV is comparatively less number of trabeculae with RV. Here in non-compaction of LV, there is n number of trabeculations present. Okay, in echo findings are prominent trabeculations in LV apex, mid ventricle, deep intertrabecular recess communicating with LV cavity, and reduced LV systolic function. So if it is reduced, LV function get reduced, the EF is about less than 50%. Okay, so once a function get decreased, there may be leads to formation of thrombus or clot. So possible in thrombus in trabecular recess, diastolic dysfunction, relaxation get impaired. Key measurements are non-compact LV, myocardial layer ratio, LVEF is more important, color Doppler assessment and thrombus assessment also must be important. See, these are the images of trabeculosis. Okay. Then visual elements are DCM, enlarged LV cavity, thin walls and showing mitral regurgitation. HCM, hypertrophic cardiomyopathy, thickened septum, SAM of mitral valve, LVOT obstruction with Doppler gradient.